Hello and welcome to this episode of our Rhinoplasty for Residents and the Foundations of Facial Plastic Surgery webinar series. We really hope you have a great time watching this show.
Thanks very much for inviting me to talk now. I am a rhinologist, so I do a lot of sort of complex rhinoplasty, but I don't do anything else, but I certainly see a lot of the functional issues. And I really probably should have George Marcells here because he's my collaborator in a lot of our research work. Now, there's no doubt rhinoplasty suffers from this. We think about it cosmetically, it suffers from the Dunning-Kruger effect where you think you know it all early on in your career. Well, I think functionally the same is true. And I think as I've gotten on in my career, I've realized that there's actually a lot to understand in rhinoplasty that can't always be expressed objectively. Now, the first thing before we talk about functional failures, I just want to touch on two things. The first thing is that how we breathe. There are not mechanical airflow receptors in the nose. And so the theories about how we breathe is really based around a pressure distension of the tissues, so a Bernoulli effect, but there's very little evidence for this. But the big one is thermal cooling. So if you cool your mucosa with airflow, you feel a greater sense of breathing. And this is why menthol, eucalyptus, tea tree oil, these medications work because they stimulate TRP receptors, which are cold receptors in the nose, and they don't make any physical change to the nose, but they actually make you feel like you breathe better. And I just want to touch on that before we then talk about the relevance of that when it comes to function. Now, functional areas in the nose, if you said to me, if I had to pick 5 things in rhinoplasty that I see consistently, both in my own practice and rhinoplasty surgeons who send me their patients for a review of why they feel like their breathing's been affected, it's the caudal septum. So everyone knows that little deviations anteriorly, classic for endonasal only surgeons are a plague of nasal valve compromise. The caudal edge of the upper lateral cartilage can produce a very similar narrowing in the internal valve, but it's not coming from the midline, it's coming laterally. I'm going to talk about that in a moment. There's obviously collapsibility of the external nasal valve, rhinitis and allergy, and turbinate dysfunction. Who you should do turbinate surgery on, and also the post-operative or post-rhinoplasty rhinorrhea. Now, for the purposes of my 12 minutes, I'm only going to talk about these two because they relate to the same area in the internal nasal valve. Let's talk about this. I actually think probably for the crowd at hand here, everyone understands the caudal septum. So here's a patient who's come and seen me. He's had an endonasal septoplasty, and on the left-hand side, he feels like he can't breathe very well. Now, I have an airway lab in which we do testing, and you can see up here the opening of the internal nasal valve on the right is good, but on the other side, it is not. You can see the spacing between the lateral wall of the nose, or the upper lateral cartilage, and the septum. So here's some static views of that internal nasal valve. Now, I think most of us as rhinoplasty surgeons, especially those who do external septal surgery, understand that all you need to do here is to get the caudal septum straight. And Tuan's touched on this. I'm a big fan of extracorporeal septoplasty that Tuan spoke about. I usually just cut the whole septum out and make a new one. And this is how I end up approaching those patients. And my goal, it's not so much a straight septum, but it's this separation. Can you see the separation between the septum and the upper lateral cartilage? And we've got it on both sides. Now, if you have a look at this patient, they've got the upper lateral cartilage and the septum separated here so that there's airflow and gap. So that's what he was before, and this is what he was after. Now, that's easy to understand. I think most of us understand if we just get a good straight septum, this will follow to get this sort of result. But let me take you through now what I think is really common in rhinoplasty, and that is the caudal edge of the upper lateral cartilage. So here's a patient who sent to me, can't breathe, doesn't understand why, sent from a colleague. Can you see how the upper lateral cartilage, it's nothing like the previous cartilage. Now, whether that's redundant, it's collapsed, but you can see I have to hold it out. And this is why patients sometimes feel like a Cottle's maneuver helps them. But you can see how the upper lateral cartilage has become distracted and sitting on the septum. And it creates the same contact point that we saw before. And if you ask me, why does this cause blockage? Because I can tell you in an objective nose lab where we do measurements of the nose, you don't actually see this physically on the testing. Because the dimensions of the airway below it are quite good, they show up as having relatively normal airflow resistance. But what it does do is that it prevents cooling or the air conditioning of the upper part of the nose. And so there's all this nasal mucosa which gets hooded from airflow and therefore doesn't get cooled, and they feel that sense of blockage. Now, let me touch on a couple of my patients. So I created it myself in some patients. Here's a septal deviation. Look, it's a huge septal deviation. There's the maxillary crest. The patient says, I'm blocked on the right-hand side. I think most surgeons here would think, oh, this is a great case. I can't wait to fix this guy's septum. And here's his result post-op. He's got a nice straight septum, a little bit of mucus up there. But let me show you, this is one of my earlier videos, my career. Look what's happened on his left. Now his septum's perfectly straight, but I've created this contact point because I've brought a congenitally deviated septum to the midline, and this person has a redundant upper lateral cartilage, and I've created a left-sided blockage in him. Now, one of the techniques you can do, so here you go here in a moment, that's what he looks like after my external septoplasty, which I thought would be a home run. And here's my previous patient who had a bent septum. You can see the difference here. This patient on the left, I've created a sense of left-sided nasal obstruction for him. Now, one of the tricks is simply just to excise it. If you've supported the nose, and as Tuan said, you've got good support to the tip, you've got a good septum, you can actually just cut this out. So I just actually put some local anesthetic in the nose. I use a straight through cut, and I don't try to do any fancy J flaps or anything else. Literally just excising the redundant part of the upper lateral. And I can tell you now, if you can, and this is the result, if you can lift that upper lateral cartilage off the septum, it ain't providing you any structural support. It is redundant at that point, if you can flop the edge around. Now, I actually look at this. This is an older video. I could have taken more there, and I'll show you some videos of what we do, now. So there we go. So here we've given him separation. So that's what I created by bringing his septum across to the midline and giving him an occlusion, iatrogenic occlusion on the left-hand side. This is just doing a simple excision, and this is how it heals down the track. So you can bail yourself out occasionally from these situations. Why does it occur? I gave you an example there of why it occurs when I brought a septum across. I also see it occurring in people who have big noses and they make their nose smaller. So we describe, a typical sort of Gunter diagram where we bring the upper lateral cartilages, we might have spreadographs and we bring it back. But if we're doing this in a big nose and we're deep projecting it, we're not really just simply doing this. We're actually bringing the upper lateral cartilage into a more inferior position in the nasal airway. And you end up with an excess of upper lateral cartilage here that's brought down into the airway. Let me touch on this, how this looks. So I'm going to show you a couple of examples now of some pre and post photos. Now, these are patients all had rhinoplasty a while ago by others and have come to me, just can't work out why it's not right. Look at this person here. Great aesthetic result. It's not a web in the nose here. It's just redundant mucosa. And look at this side. I can actually place the FRIA like about 5 millimeters. Look at that, behind that internal valve. This is not a stenosis of the internal nasal valve. It's just where the upper lateral cartilage has been brought down too low. And simply in this patient, if I go to the other side, simply just excising it and placing a silicone sheet in, and I'll show you how I do the silicone sheet, gives us this view here. So we've been able to restore that cleft, that separation. And you can see it's not perfect. That's where my silicone has been sitting. You'll see in a moment where that silicone sits. And so you get a little bit of webbing, especially when it's almost solid tissue up there. That's the right-hand side. And even on the left-hand side, we'll have a look here in a moment, you can actually see we've been able to restore a separation between the upper lateral cartilage and the septum, almost right up to the top. Now, how do I do it in actual the procedure itself. So I use little silicone sheets. I do this in all primary rhinoplasties, but if I actually take someone back to theatre to excise their upper lateral cartilage caudal edge, I put these silastic sheets in. They're just 1.5 millimeter silastics. They're not quite perfect tubes. I can share that with you later on. And you put one suture down the bottom, but most importantly, the second suture, you drag the silicone tube up so that it really jams itself into that internal nasal valve area. And by dragging the silicone up, you really then shove it up. And I don't have a perfect video here. I have to get a better endoscopic view where it sits right up high in this internal nasal valve area. And by doing that, you really support the tissues there and you prevent the collapse. Now, I know that often in rhinoplasty techniques, people have lots of ways of compressing the mucosa around the internal nasal valve, sometimes through and through sutures. I find that this soft silicone sheet allows you then to compress your external cast over it, and you still get a very nice settling of the soft tissues over the top. Here's another person here on the left-hand side. This person's once again had 2 previous rhinoplasties, great aesthetic result. But look at this. I mean, forget the adhesion here. Even if the adhesion wasn't here, the complete contact of that area between the septum and the upper lateral cartilage creates a sense of congestion. And this person's also got a small degree of rhinitis. And here he is, this side's not an adhesion, but that redundant cartilage. And so once again, I've formally excised that just endonasally. And then this is what you get after formal excision and placing those silicone sheets in. Now you can see once again, the silicone sheets have just come out. We've got this nice separation. You can see me palpating the side wall. You get reasonable support there. We'll go to the other side. And then here on the other side, we've got that support. Instant relief of their perception of nasal obstruction. Now, prevention is better than the cure. So here on the left-hand side, I just want to show you here, this is someone who has a very big nose. And so when I bring the upper lateral cartilages back to the septum, I simply just don't suture them to the septum and don't think about it. You can see here in this person, I'm going to end up with an upper lateral cartilage, which is longer than the actual septum. And so actually excising a triangle of that caudal edge of the upper lateral cartilage is what's required here. Now, this is something that's not traditionally been spoken about in rhinoplasty, but I think it's relevant because if you said to me, what am I doing endonasally to salvage those other patients? I'm simply excising this area because it's become redundant later on. Now, that's all for me from today. There's a lot of other areas that the rhinoplasty surgeon can go wrong, and I think that's all for another time. Thanks very much.
Yeah, Richard, fantastic. That really, thank you. That's so interesting. It's made me look in a different way now to understand what you're doing there. Can I ask a quick question in terms of that splint you put in? So if this is the nostril, do you stitching it against the septum and then does it come up and onto the outside?
So it is Cameron a tubular splint. I use a Medtronic 0.5 mil silicone sheet. I cut it in half and I create 2 tubes, and I do shave a corner off one of the tubes so you can sit it in the nostril and the bottom doesn't stick out in the sill. So I put a suture in down below first, and then I drag the tube. So you turn it from a perfect circular tube into an elongated tube by shoving the tube up into that upper lateral area. And whatever redundant mucosa we may have created during our rhinoplasty, or just for the same, if there's just redundant mucosa, full stop, from going from a big nose to a smaller nose, it allows that tissue to compress out and really preserve that apex of the internal valve. And this has been by far and away the most successful intervention that I've had in terms of preserving that post-rhinoplasty. And so I use those silicone tubes early on just for this situation, but now essentially every rhinoplasty I do, I put these silicone tubes in. Now, of course, once you put them in and you look at the nose, you can see this distension in that intercartilaginous area. But if you can place a normal compression cast, an external splint on it, and it actually gives you something to compress down onto.
Yes.
And the other advantage of the silicone tube, Cameron, is that it also prevents over-medialization of your bone at that area too, because the silicone tube's about sort of 15 mil wide, 15 mil long. And so just helps just that interning, that over-medialization sometimes of a mobilized bone. That's the other thing I think it helps you as well.
So one last question, how long do you leave them in for?
So for me, I leave them in, if they're in a primary rhinoplasty, I leave them in 2 weeks, because they come back at 1 week to have stitches taken out of the columella or alar base. I actually leave the cast on for the 2nd week, and they have these tubes in. Remarkably, Cameron, they breathe quite well through the tubes. You know, they're actually one of the better options for post-rhinoplasty breathing. And then they don't like it, of course. I mean, no one likes having their dressings in their nose, but at day 14, you take it out. You've really been able to get the patient through to that point where the soft tissues are stable. And everyone knows that by the time you take a cast off at day 14, you know, people have a pretty nice looking nose. And so you can then sort of, you know, send the patient on their way for a 3-month review without worrying too much more about it.
Wow. Well, thank you very much. I think I've got to get back to Sydney and come and watch you operate and see George as well. Yeah, Richard, we really appreciate your time. And it's now what must be coming on just after 5 o'clock in the morning for you. So
Yeah,
I hope you have a
my
great
pleasure.
week.
Thanks for having me.